Hi, everyone. Good morning, good afternoon, good evening in your respective geographies. I'm so happy to see you all here, new faces and familiar faces, and I'm looking forward to when we can all be together again. But I want to thank you for joining us and helping us celebrate World Asthma Day, where this year we're really focused on uncovering the misconceptions around asthma. We made a great video that's now posted on YouTube with some submissions from all around the world where individuals talked about something that was pertinent in their respective country that they tried to correct, like a myth that's floating around. So I'd encourage you to go out and try to see that. For questions today, we're going to collect all the questions in the chat format. So if you could please just post your questions, and then after we're finished with our presentations, we're going to address each question. I believe that would be the most efficient way. And just a reminder, today's session is being recorded. We're going to post this on the YouTube and GINA website and a couple other social media outlets. So if that's an objection for anyone, please let me know in the chat feature. With that, it's my privilege to turn over the microphone to the chair of the GINA Board of Directors, Louis-Philippe Boulet. So thanks again, everyone.
Well, thank you very much, Rebecca, for organizing this session. I think it's an opportunity for us to gather to chat about the activities at GINA, the knowledge translation activity, particularly the dissemination and implementation of GINA. And I think we will have an interesting session today. So good morning, good afternoon, or good evening to all of you. I will try to start my slides. Let me see. Okay, is it okay? Do you see the slide? Yes. Okay. So okay, today is World Asthma Day, and I think it's an opportunity, as I said, to discuss about asthma, to discuss about GINA initiative, and how can we better, in fact, disseminate the report. I think you're all aware of the many components of our website, which is one of the main way to disseminate GINA. I think we have a lot of visitors on this website. And I think, however, it's not everybody that is aware that we added many components to the website to facilitate implementation in local area. In fact, we have now the frequently asked question, we have different sessions, in fact, video, podcast, different components that could be used, in fact, for implementation. And of course, now we have the GINA Advocates. Many of you are now advocates, which is a select group of people that help us, in fact, to disseminate and help implementation of GINA. We have the online courses, so we have many activities, and I think in the near future we could have more gathering of this type like today, in fact, to discuss about how to improve this. You know the structure of GINA. I'm the chair of the board of directors. Helen Reddel is the chair of the Science Committee. I have the chance to co-moderate this session this morning with my colleague Arzu, who is the chair of the Dissemination and Implementation Committee. And of course, now we have our GINA Advocates in addition to the General Assembly. So World Asthma Day is a long-standing activity. In fact, it was founded in 1993 as a collaboration between the GINA, in fact, and many other national bodies and organizations. So each May, we have the opportunity to raise awareness about the problem of asthma in the world, which is still amazing. And of course, with the progress of treatment and assessment of this condition, we have to update regularly our condition and help, in fact, our colleagues and also the patient to better manage this condition. The goal of this meeting, as I said, is to discuss first the status of asthma worldwide. It will be interesting to hear about successful national initiative on asthma management. Helen will provide an update on the 2021 GINA report, which just came out last week. So I'm sure you'll be all interested to discuss the new components of the report. And of course, a larger component of the session will be a discussion about how to better disseminate and foster implementation. And we have, in fact, many short presentations. Unfortunately, Tyreek would not be with us today, but we have everybody else. And following the short presentation, I think we'll just keep the questions for the discussion period. We have sufficient time for an interesting discussion. And of course, feel free at this time, if you have any question to the speakers, or if you want to have any comments or suggestion, feel free to do so. So without any further ado, I will ask my colleague Arzu, in fact, to speak about the GINA D&I plans for 2021. Arzu.
Thank you, Louis-Philippe. I would like to share my screen. Can you see my screen?
Yeah.
Okay. Hello, everyone. It's so nice to see all of you. We hope to meet in person, but this year pandemic is still a problem in the world, all around the world. So maybe next year we will get together. And it's also very good to celebrate World Asthma Day together. And as Louis-Philippe has said, you will have the privilege of listening 2021 revision of GINA from Helen from the first hand. This is GINA. This is the board of directors and the science committee, one of our London meetings. And we are very much hoping to have the new one. And as Rebecca and Louis-Philippe also mentioned, this year's theme is uncovering asthma misconceptions. Thanks a lot for many videos from all of you sent us, and they have been posted on GINA website, and it's very successful. Here are our advocates, and I hope a majority of dear friends will join us today. We have Africa, Americas, Asia, Europe, and Oceania, and very happy to be GARD family, a global GARD family all around. Our first meeting, as you can remember, was in September 2020. Alvaro Cruz was chairing the D&I committee then, and he organized this meeting, and it was very successful, and we had the chance to discuss many things. But today's meeting, we have just extended the duration of the meeting a bit for 2 hours, so we're not going to talk too much. We would like to listen to you and have your suggestions and have your recommendations for the future of GINA and GINA D&I committee. This is the D&I committee. Louis-Philippe Boulet was the chair, and after him, Mark Levy, and then Alvaro Cruz, and here, myself, I had the privilege to chair for this year. And we have lots of materials on our website. Please go visit our website. You will find an incredible work and incredible material to use in your D&I activities in your country. What we are planning to do for this year and the following years is we have planned podcasts, and for every 3 or 6 months we are trying to update those podcasts according to the following the agenda of the respiratory diseases, mainly asthma. And also we are preparing monthly messages, and we are using the social media, Twitter, Facebook, or the Instagram, to deliver our monthly messages. And if you can deliver those messages in your country, it will be our pleasure, and we can reach a broader, wider population. And also we are working on some report dissemination alternatives, and we will let you know when we finish. And also we can have your suggestions on this today. And for the GINA Advocates country activities, we very much would like to have your activities and to post those activities on our website. So here we, as the DNI committee, prepared some topics to discuss. Maybe we can use it in the group discussion, but just to give you an idea, how can GINA help you with implementation in your country? How can you help GINA implementing optimal asthma management, which is more important, and digital health, involving patients and patient groups, many issues to discuss. I can bring this topics in our discussion session, and very much would like to hear your suggestions also. As I always state, we are together, GUARD, GINA, GOLD, and here as ATS and FIRST, and our job is preventing and controlling chronic respiratory diseases and keeping them on the global health agenda. And it will require energies of all of us in the respiratory community. We shouldn't duplicate the efforts, make the things copy and paste, but we should join our efforts. And I believe that COVID pandemic is a window of opportunity to promoting respiratory diseases. We have gone through very bad things, but we have the positives also. And I believe that the world will look in a very different way in a year's time, and the positives can be noted, like the spirit of international collaboration, like we are experiencing today, breaking down of geographical barriers, widespread sharing of data, and the global appreciation of dedicated healthcare workers. So thank you very much. This was I am stopping to share. This was my presentation. And now I would like to give the floor to Sarah Rylance, my dear friend. And I am so happy to work with her in WHO GUARD. She is the medical officer for chronic respiratory disease in the non-communicable disease department in WHO headquarters. And she's going to talk and give us WHO perspectives on asthma. Please, Sarah, the stage is yours.
Thank you very much, Arzu. Thank you for introducing me. Give me 1 second to bring my slides up. Okay, hopefully you can see my slide. Yeah, great. Okay. So good morning, good afternoon, good evening to everyone. As Arzu said, my name is Sarah Rylance. I'm the medical officer responsible for chronic respiratory diseases within the non-communicable disease department at WHO headquarters. And specifically, my work relates to the diagnosis, treatment, and monitoring of asthma and COPD. Firstly, I would like to thank GINA for inviting me to join with you all today. It's a real pleasure to be here and to give this brief overview on the WHO perspective on asthma. I'm going to start by discussing asthma as part of the global non-communicable disease agenda, and then briefly discuss the WHO resources relating to asthma, and finally think about how we can work together to advance asthma care across the globe. So there's been increasing global recognition of non-communicable diseases, or NCDs, over the past decade, with a clear mandate from member states through the World Health Assembly and United Nations General Assembly to drive the work of WHO. In the past decade, there have been 3 United Nations General Assembly high-level meetings on NCDs. The outcome of the first in 2011 was the UN Political Declaration on NCDs, and following on from this, the WHO Global Action Plan for the Prevention and Control of NCDs was endorsed by the World Health Assembly in 2013. The Global Action Plan contains 9 voluntary targets, including a 25% relative reduction in premature mortality from cardiovascular diseases, cancer, diabetes, and chronic respiratory diseases, including asthma and COPD, by 2025. And there are also targets relating to the availability of medicines and technologies and reducing tobacco use. Subsequently, the 2030 Agenda for Sustainable Development was adopted by the United Nations in 2015. Sustainable Development Goal 3 includes targets to reduce mortality due to NCDs by 1/3 and achieve universal health coverage, including access to safe, effective, quality, and affordable essential medicines for all. SDG 3 also supports the implementation of the Framework Convention on Tobacco Control. These high-level political commitments relating to universal health coverage are reflected in the current WHO Programme of Work, or GPW 13, which covers a 5-year period from 2019 to 2023. This work plan was approved by the World Health Assembly and includes 3 interconnected strategic priorities: achieving universal health coverage, addressing health emergencies, and promoting healthier populations. Activities to address this triple billion goal will be delivered across the 3 levels of the organisation at headquarters, regional offices, and country offices. And so there is a high-level commitment to tackle NCDs, including asthma, with a strong emphasis on universal health coverage. In order to address this, WHO has developed a package of essential non-communicable disease interventions, more commonly known as the PEN package, which was first introduced in 2010 and recently revised in 2020. The package is targeted at primary health care level in low resource settings. PEN contains a module on chronic respiratory diseases with protocols for the assessment, diagnosis, and management, both acute and long-term, of asthma and COPD. Also relevant to chronic respiratory disease care, there is a healthy lifestyle counselling module, which includes counselling on tobacco cessation and a brief self-care module. PEN also includes protocols for the other main NCDs, cardiovascular diseases, diabetes, and early diagnosis of cancer. The uptake of PEN in countries has been quite variable, with most activities relating to the implementation and evaluation of the cardiovascular and diabetes protocols. Clinical assessment of blood pressure or blood glucose is relatively simple, and so these conditions lend themselves to screening and monitoring with clearly defined and measurable indicators to track progress. And so let's talk briefly about the PEN protocol for asthma. I've included a link on the slide, and you can easily find the PEN document on the WHO website. Asthma exacerbations are managed with oxygen, salbutamol via an inhaler and spacer or nebulizer, and oral prednisolone. If second-line treatment is needed, PEN advises nebulized salbutamol and nebulized ipratropium if available. The long-term management of asthma in PEN follows a stepwise approach, starting with as-needed inhaled salbutamol, adding in inhaled beclomethasone, then low-dose oral theophylline, and then low-dose prednisolone if needed to achieve control. Those medications marked on the slide with an asterisk are included in the PEN core list of medicines for primary care facilities with physicians. I'm not going to talk about the GINA report because other people are going to be talking about that today, but I include this slide to highlight the differences between the medications recommended in PEN, those included in the most recent WHO essential medicines list, and those included in the last GINA report. PEN has been developed for low resource settings, aiming to strengthen primary healthcare and provide a minimum level of care for all. This clearly differs from the target audience and scope of the GINA report. But for healthcare providers at referral level and policymakers in low and middle income countries, it can be quite difficult to know what treatment should be prioritised, particularly when evidence for clinical and cost effectiveness in low resource settings is lacking. Access to essential medicines has been a challenge in asthma care for decades. Salbutamol and steroid inhalers were first introduced over 50 years ago, and yet there are still many countries in which patients are unable to access a reliable or affordable supply of medication. This slide shows the results from the last WHO NCD country capacity survey in 2019 concerning the availability of steroid inhalers and bronchodilators in primary care facilities in the public health sector. The first 4 rows relate to World Bank income groups, so low income, low middle income, upper middle income, and high income countries. The 6 rows below relate to WHO regions, the African region, Americas, Eastern Mediterranean, European, Southeast Asia, and Western Pacific regions. So you can see in low income countries, bronchodilators are only available in half of countries and steroid inhalers in less than 1/5. Steroid inhaler availability is particularly problematic for countries in Africa and Southeast Asia. And so how can we make progress to improve asthma care across the globe? This depends largely on political will. Patients and their families, local communities, healthcare providers, and professional organisations need to deliver clear and coordinated messages to their governments, advocating for better monitoring, diagnosis, and clinical care for chronic respiratory diseases. These government representatives feed into the World Health Assembly to direct the work plan of WHO, across the 3 levels of the organisation, in countries, regions, and at headquarters. This slide shows the web of connections between key stakeholders. Everyone has a part to play in raising the profile of chronic respiratory diseases. Healthcare providers include those across all levels of health facility in both the public and private sector. Nurses, doctors, pharmacists, community health workers, physiotherapists, and other allied professionals. In order to achieve progress, we need to work together to understand the needs of patients, develop solutions that are tailored to the communities where they live, and develop people-centered primary healthcare with access to appropriate referral and support systems. There are many competing priorities. In order to progress universal health coverage, services must be integrated to take advantage of synergies with other conditions which share diagnostic features, investigations, or treatment pathways. There are many challenges to overcome, such as lack of awareness among communities and healthcare providers, inadequate equipment, human resources, training and supervision, and inequalities in access to treatment, including inhalers and tobacco cessation support. But as Arzu has already mentioned, the time is right for change. The COVID pandemic has emphasized the crucial interplay between acute infection and non-communicable diseases. There are concerns about the burden of long-term sequelae in countries across the world, and the critical importance of lung health has been highlighted. The global respiratory community must work together to maximize this opportunity and catalyze progress in the care of chronic respiratory diseases. The GINA Advocates are a wonderful resource for the global asthma community. You have a crucial role to play in improving asthma care in your own countries and further afield. I encourage you all to be advocates not just for GINA, but for your patients, their families and communities and your colleagues, and to continue to help raise the profile of asthma on the international health agenda. And so finally, I would just like to take 1 minute to mention GARD, and Arzu has already mentioned, the Global Alliance Against Chronic Respiratory Diseases. GARD is a voluntary alliance of national and international organisations, institutions and agencies committed to the vision of a world where all people breathe freely. GINA is a member of GARD, and I know that several of you have already been involved with GARD activities. But for those of you who have not, please consider linking up with Arzu or Louis-Philippe or myself to understand more about how you and your country could take part. Thank you for your attention. I'm happy to take questions later and look forward to hearing your thoughts and joining in the discussion. Thank you.
Well, thank you very much, Sarah, for this very interesting presentation showing the actions undertaken by WHO to improve asthma care worldwide, and also the barriers and some quite interesting opportunities that we will have to face this problem or to improve this condition. Now I would like to ask Todor Popov to speak to us about how can advocates help promote GINA more effectively. I think Todor is with us presently. Hi, Todor. Todor is a professor at the University Hospital of Sofia, Bulgaria, and is one of our GINA advocates. He has contributed to GINA activities for a very long time. He's a clinician and researcher. Todor, we are very happy to have you with us today to speak about how can we improve, in fact, the actions of advocates with GINA. Thank you for being there.
Thank you, Louis-Philippe, for the generous introduction. Dear colleagues, advocates and GINA activists as well. As heard already, I'm from Sofia, Bulgaria, from the University Hospital Sveti Ivan Rilski there. I'm going to share with you my view on how advocates can potentially help with GINA more effectively. I have no conflict of interest. Actually, I didn't share my screen. Shall I share my screen and go ahead with that? Sorry.
Yes, please do. Thank you, Ted.
Sorry, I thought that it's automatic. I'll do that now. Can you see it now?
Yes, very clearly. Thank you.
Okay, that's right. So I have no conflict of interest in relation to the presentation. And I'll start my presentation in the Middle Ages. Don't panic, it won't take that long. And I'm going to mention to you something that you might not know. something that has to do with our predecessors in a way. Have you heard the word dragomans? Actually, these were very highly educated people speaking several languages and serving as intermediaries between the Orient and the European embassies, consulates, and trading posts. The center point of the dragomans at the time was Istanbul, and Arzu. That's something that you must have heard and know about. They were the transmission of trade and diplomacy in the old world. Now, back to the present, we call ourselves advocates. One of the meanings of advocate in the Merriam-Webster dictionary, which suits best our purpose, is one who supports and promotes the interests of a cause or group. This was one of the dragomans, by the way. His name was Amédée Joubert, Napoleon's favorite Orientalist advisor. He accompanied on this picture, painted by François Mullard, the Persian envoy Mirza Reza Kazvini, to meet Napoleon for the Treaty of Finkenstein. Just to give you an idea, this is basically the dragoman, and this is the envoy, and this is Napoleon. I shouldn't mention that. So back to my definition of advocates: one who supports or promotes the interests of a cause or group. The purpose of the GINA Advocates is to be an interface between the leading experts formulating the evidence-based and regularly updated messages of GINA on one hand, and the healthcare authorities, non-government organizations, and patients' communities on the other. On this next slide, you can see a plate with the block scheme of an electronic interface. As you can see, the advocates are the connectors here in the middle. They are the connectors between the different bodies of the Global Initiative for Asthma of GINA on the left side, the GINA Scientific Committee, GINA Board of Directors, GINA Dissemination and Implementation Committee, and all the other stakeholders. Of course, we have the patients and NGOs, we have the healthcare providers, we have the media, and many others that are sort of linked to the central function of the GINA Advocates. On the next slide, I have formulated my understanding of the mission of the advocates, and it is to disseminate and implement the GINA goals of optimal management of asthma around the globe, to influence the behavior of healthcare professionals and patients, to find ways to introduce the evidence-based strategy of GINA in clinical practice, to adapt the strategy of GINA across the spectrum of variable populations and health systems worldwide. There are certain prerequisites for our success as advocates. We need to have access to the most up-to-date information on the latest GINA documents. We were privileged to get in advance the GINA 21 report. However, the most important issue is that we harmonize our understanding among ourselves of this report so as to provide the same interpretations no matter where we are. And it's not an easy task because, as you can see, this is the updated version, which is still confidential in a way. It has 220 pages in 8 chapters, 29 tables and figures, 815 references. So it's a huge amount of information that we have to digest and to spread it around us, to translate it to the different languages that we will be responsible in a way for the different countries. And The good thing is that there's a section of the GINA report 21, which says what is new in GINA 21, and it's already something which is much more manageable when you look at it. Still, I'd be very much, I'm looking forward with much interest to hear one of the authorities on GINA, Helen Reddel, tell us about what's new in GINA 21, and I wouldn't indulge in that any longer. But I have a suggestion to set up a repository of questions from the medical community that we collect from the different places we are active in, so that we give the coordinated uniform responses to different ambiguous answers, questions that we are asked. This might be something that needs to be continuously updated and continuously spread among us. To continue with the prerequisites for the success, we must play the role of point of reference about the current understanding of underlying disease processes. We need to understand and influence the behavior of healthcare professionals and patients. We need to find ways to introduce the evidence-based strategy of GINA in clinical practice and to adapt the strategy of GINA across the spectrum of variable populations that I mentioned. What would be the means to create to accomplish our mission? It would be to create local groups of supporters in the countries of origin, to establish connections with the healthcare authorities, health insurance funds, and lobby for positioning of asthma as a health priority, to seek opportunities to raise awareness of the society about the burden and nature of asthma through specialized and public media. We have to work together with primary care and patient organizations. We have to foster the setting up of interest groups involving asthma specialists, primary care physicians, to introduce the evidence-based strategy of GINA in the clinical practice. And again, we have to be creative. We have to be creative so as to adapt the strategy of GINA in the different parts of the world. I wouldn't take too long, and I would finally state that I hope that we as a group can use our creativity and expertise, of course, to further develop the concept of GINA Advocates to successfully implement GINA's evolving strategy. Therefore, it would be important to share positive and negative experiences between ourselves, for which purpose we should all have a list of our names and contact details and be in position to call each other, depending on which part of the globe we are situated, so that we can find the best counsel from those who have some similar problems. So I thank you for your attention, and I believe these core ideas might be supplemented by feedback from all advocates. Thank you.
Thank you, Ted. I cannot agree more with your recommendations and the suggestions and the work plan. Thank you very much for sharing this with us. I think we will discuss it in the discussion part of our webinar, and we're going to maybe plan new activities together as a community of the GINA. Now it's my pleasure to introduce Michaela Odamer. I don't know if she is with us. I know she recorded her presentation, and Michaela is a very good friend. She's going to present us patient perspective on implementation. She is the current president of the European Federation of Allergy and Airway Diseases Patient Association. She's also a member of European Lung Foundation. Yes, we
Good
are
day to you all,
ready.
and thank you for having me. My name is Michaela, and I am the president of European Federation of Allergies and Airway Diseases Patients Association, which connects 39 allergy and asthma and COPD patients association across Europe. I am a mother of 3 children with allergies and asthma, and I'm a patient myself, so I know firsthand how chronic conditions such as asthma can be very limiting and exhausting without the right implementation guidelines. From a patient side, we see many challenges facing the proper implementation of treatment and management of asthma, a powerful tool that can empower patients and healthcare providers alike in the GINA patient guide. However, we see that most asthma patients are not aware of its existence, and it's also limited by only existing in 7 to 10 languages, considering that there are 24 official languages in Europe alone. We can see how barriers to this vital resource exist, and we need to see this guide translated into more languages spoken globally and reviewed by patient organizations to make sure the language is still accessible to patients. Patient organizations work closely with asthma patients and can help to share the guidelines once they become more accessible. To improve the implementation, we need also involve patient organization in the development of tools and materials so that they are created by patients for patients. Patient organizations are key to improving implementation, and we are always ready to support the work of others to see that patient voice is in the center of initiatives. People's ability to take charge of their own healthcare should be guaranteed everywhere and to everyone in Europe. Unequal access to healthcare remains a problem. In 2019, IFA launched the Active Patient Access Care Report to measure the current restriction in access to healthcare. The report also offers recommendations for policymakers, healthcare professionals, and patients to reduce the inequality. IFA interviewed patients with asthma and COPD from 7 countries: Finland, France, Germany, Italy, Poland, Spain, and United Kingdom. In total, there were 774 interviews covering asthma and COPD equally at the different level of severity for each. The result of the report can be used to identify areas where improvement can be made and to promote the mechanisms to create change for patients. While the survey found an average of 3 years for a first diagnosis, a positive sign is that patients we surveyed went through diagnostic tests recommended in the most recent GINA guidelines, including lung function or spirometry testing, and to document variable expiratory airflow limitation, including the use of a relief spray when needed. Based on these results, IFA recommended the healthcare workers more education in use and interpretation of diagnosis tests, and to connect with the specialist when uncertain rather than relying on trial and error tests. IFA also recommended the use of specialized centers equipped with the latest diagnosis and tests and specialists. 60% of respondents reported a misdiagnosis, and 60% of respondents believe that their asthma cases go unreported, which could be based on unreported symptoms due to lack of knowledge from patients or a lack of diagnosis based on deficient healthcare system and poor patient-doctor communication. We need further research to understand the reason for misdiagnosis and to identify best practices to reduce this. A patient-centered detection and reward chain should be put in place that lead to early correct diagnosis. We also believe that patients should be empowered and able to request different and appropriate diagnosis tests if they feel they haven't received the right one. Then can also include the use of digital options such as mHealth and online tests. The report also revealed that asthma patients rely on healthcare professionals more than expected. It is unsurprising that 85% of patients with severe asthma see a pulmonologist often, but what might be surprising is that 2 in 3 of patients with mild asthma also see a pulmonologist. The suggestion that the most patients have problems with managing their asthma. Patients who do not regularly see a specialist report that is either because their asthma is under control or that they trust their primary care doctor to provide adequate care, or that they never discuss the possibility with their primary care doctor. It should be the case that mild asthma can be managed by patients and their primary care doctor, while specialist advice is needed for specific reasons, such as persistent uncontrolled asthma, risk factors for asthma-related death, significant treatment side effects, or symptoms suggesting complication or subtypes of asthma. What we also have seen is that 26% of asthma patients ended up in the emergency room at least once a year, meaning that their asthma does not respond to the treatment prescribed. It is important that healthcare practitioners use personalized medicine where needed and always in the case of severe asthma. Doctors should prescribe and follow the right treatment for the right patient based on guidelines and shared decision-making. Two-way digital tools should be used for follow-up and adherence to treatment. An alarming reveal from the report is that in general, satisfaction with public authorities in reducing exposure and protecting patients from risk factors is low. Meanwhile, patients are aware of what triggers their health condition, especially when it comes to individual risk factors like stress or anxiety, and outdoor and indoor air pollutant that need to be addressed in policy. To help empower their patients, healthcare practitioners should work to involve patients in decision-making around their treatments and use tools to help patients understand fully their asthma action plans and to support self-management. Patients want to see health authorities and healthcare professionals investing in the implementation of asthma disease management guidelines, such as GINA and ERS ATS, so that every patient has a self-management plan to be in control of their symptoms and reduce the need for relief medication. We also need healthcare professionals to follow up on these self-management plans and provide education on their care techniques, especially on inhalation techniques, and to motivate patients to get in contact with local patient organizations or support groups. By doing so, healthcare professionals empower patients to get patient-friendly information, peer support, access to educational tools, materials, and training. And for policymakers, the report recommended facilitating the digital transformation of healthcare and to help empower patients. Policymakers should also work as a healthy lifestyle and living well as a part of a good self-management. The report also provides recommendations by patients to patients. Patients should have access to education either personally or using digital tools on asthma, its causes and treatment, and living with a chronic disease. Patients also need to be able to understand how to balance the side effects and the benefits of medication. Thank you so much for listening.
Well, this was a very interesting presentation. I just heard that Michaela sends her greetings. She's speaking at another World Asthma Day meeting in Sweden presently. But I think this presentation shows us very well some quite significant care gaps. In fact, that are discussing for the last, I've been discussing for the last 30 to 40 years. Over and under diagnosis of asthma, problems in management and self-management, particularly need for more education and improved communications between patients and healthcare providers. So this is so revealing to hear presentations coming from our patients' representatives. So right now I'm very honored to present the chair of the Science Committee of GINA, Helen Reddel. I think Helen doesn't need any presentation. She's a professor at the University of Sydney Medical School, and she's working at the Woolcock Institute of Medical Health and Medical Research in Australia, where I had the chance many years ago to spend a few months. So I think we're very lucky to have Helen as a high stature scientific clinician, and I think she will summarize then in the next 30 minutes the new aspects or the new components of the GINA 2021. So thank you very much, Helen.
Thanks very much, Louis-Philippe, for that nice introduction. Now, hopefully you can see this. Let me just go to slideshow. Right. Okay, well, it's lovely to meet you virtually. And you know, I really do hope that we'll have the opportunity for face-to-face meetings soon. I'm going to give you a summary of some of the changes in GINA 2021, particularly focusing on the most important ones. But you do in fact have access to a slide set on the GINA website that will give you more information. This is my statement of interest. So I do provide a lot of independent medical advice and present the GINA recommendations at as many symposia as I can, in fact, to disseminate the work. So this is just the front slide for the slide set that is on the GINA website, and I'd encourage you to use this and use however many of the slides that you need. So just a reminder about GINA's long history. And I think there's perhaps some misunderstanding in some areas about the aims of GINA. So certainly to increase awareness about asthma. And we should perhaps think of rewording this to improve asthma prevention and management through a coordinated worldwide effort. So that doesn't actually summarize the intense focus on evidence as part of the GINA recommendations. So the GINA report is global, so not nation specific, it's evidence-based, and it can be adapted for your local health systems and medicine availability. It's very widely used, and it has a practical focus in terms of clinician tools. Unusually, the GINA report is updated every year. So we do a twice yearly cumulative review of new evidence across the whole asthma strategy. And there are some important differences from the ways that that other guideline systems operate, which we may come to later on if there's time. In particular, the recommendations are not framed just as answers to isolated PICO questions, but they're framed as part of an integrated asthma strategy across asthma severity, across a patient's lifetime for both symptom control and risk reduction. The evidence that we consider, yes, includes randomized controlled trials. They're the bread and butter of evidence, but GINA also takes into account observational studies to supplement the findings from clinical trials, or where clinical trials are not possible. We look at meta-analyses, and of course we look at grade reviews if and when they're available, but that often doesn't come until at least a year or two after a recommendation is initially made. And we include qualitative research as part of our evidence base. We pay critical attention to the clinical relevance of study design and the generalizability of the populations. And there's a fairly striking difference in some cases between the studies that we will include as part of the evidence base and those that may be selected by systematic reviews that don't take into account the clinical relevance of the study design. For new therapies, we usually require at least 2 high-quality randomized controlled trials or at least multi-center studies. plus approval by a major regulator. And that's really for us because of the amount of safety data that's available to regulators compared within the peer-reviewed literature. But as you know, since 2018, we've also made recommendations about existing therapies, even if they're not approved by a major regulator. And then the other considerations in making recommendations include patient priorities and preferences, patient behavior, including patient adherence and whether it's likely with particular strategies. We take into account our current understanding of underlying disease processes, and we take into account the feasibility of recommendations for implementation in clinical practice. And then, of course, the global variation in populations, in health systems, and in medication access. So I just want to show you one slide from summarizing the current advice on the GINA website about COVID-19 and asthma. So you can find, I think it's 5 or 6 slides on asthma and COVID on the GINA website. And this was updated just a couple of weeks ago. So in summary, overall, from very large meta-analyses, people with asthma do not appear to be at increased risk of either COVID-19 or of severe COVID-19. However, in 2 studies, the risk of COVID-19 death was increased in people with severe asthma, although in one case that was defined by recent use of oral corticosteroids, which may just mean uncontrolled asthma. Interestingly, in 2020, very many countries observed a reduction in asthma exacerbations and in influenza-related illness. And it may be that respiratory infections, viral respiratory infections, which in the past we regarded as relatively unavoidable, can in fact be controlled by the strategies such as masks, hand washing, staying home from work if you're unwell, etc., and physical distancing, that they can in fact reduce a lot of viral infections as well as COVID. It's important during COVID to advise patients to continue taking their asthma medications, and particularly inhaled corticosteroids, because they reduce the risk of exacerbations and uncontrolled asthma. Make sure that all patients have a written asthma action plan that calls for an increase in maintenance treatment as well as reliever treatment. And then for patients with severe asthma, continue biologic therapy or oral corticosteroids if prescribed. Early during the COVID pandemic, there was concern that oral corticosteroids may in fact worsen the situation because of some precedent with the earlier SARS epidemic. But I think that that has now been put to rest. And in fact, there's some preliminary evidence, although some unpublished yet, suggesting that inhaled steroids may possibly be protective. Of course, follow strict infection control procedures if aerosol generating procedures are needed in the case where community transmission is occurring, which is in most countries in the world. And in particular, avoid nebulizers where possible to reduce the risk of spreading virus. That's been a recommendation for many years, but it's particularly important in the context of an easily transmissible infection like COVID. And then there are a couple of slides in the set about the recommendations around COVID-19 vaccination. So with the qualifier about not using the Pfizer and Moderna vaccines for people with an allergy to polyethylene glycol or other vaccine ingredients, GINA does recommend COVID-19 vaccination for people with asthma. The usual vaccine precautions apply. Don't give the vaccination if the person is unwell at the time, and always ask about allergic reactions. However, given the high proportion of people with asthma who have allergies and some who have anaphylaxis, it's important to emphasize that anaphylaxis to food or insect venom or other medications is not a contraindication. And then based on consensus, we suggest that COVID-19 vaccination should be given on a different day from biologic therapy for severe asthma, just to make it easier to identify, to distinguish adverse effects from each of those, and with a gap of 14 days from influenza vaccination. I want to move on now to treatment of asthma in adults and adolescents. I want to emphasize the importance of this arrowed circle, because what it does is to summarize in a way that you can use in asthma education all of the key elements of asthma management. And in particular, that it's not just about symptoms and lung function. It's not just about medications, and it's certainly not one size fits all. So an emphasis on assessing modifiable risk factors and comorbidities, inhaler technique and adherence, absolutely essential. And here we importantly include patient and parent preferences and goals. And then treatment is not just medication, but also treating those modifiable risk factors and comorbidities, using non-pharmacological strategies and education and skills training. And then when reviewing the response, it's not just about clinical outcomes, but also making sure that you assess patient and parent, for children, satisfaction. Just a reminder about the key change that was made in recommendations in 2019, that treatment of asthma with short-acting bronchodilators alone is no longer recommended for adults and adolescents. And really, this was a safety recommendation. It was based on evidence that SABA-only treatment increases the risk of severe exacerbations, and that adding any inhaled corticosteroid significantly reduces that risk. So GINA now recommends that all adults and adolescents with asthma should receive ICS-containing controller treatment, in particular to reduce the risk of serious exacerbations, but also for symptom control. And of course, in mild asthma, that can be given by as-needed low-dose ICS formoterol, or across all of the treatment steps by regular daily treatment. Now, it might be helpful to explain when you're describing the GINA strategy that this, in mild asthma, is a population-level risk reduction strategy. So think of the way we manage high cholesterol or high blood pressure. We don't expect individual patients to experience or even be aware of any short-term clinical benefit, but the aim of the treatment is to reduce the probability of serious adverse outcomes at a population level. The problem in asthma, of course, is that patients do have symptoms, and it's difficult for clinicians and patients to go beyond thinking of symptoms as being the key measure of success of treatment. And then as background, the risks of so-called mild asthma, that patients are still at risk of serious adverse events, such as acute asthma or near fatal asthma, or even fatal asthma. And these proportions of patients who, when assessed, had symptoms less than weekly in the previous 3 months. And that level of frequency of symptoms is not normally considered to be a risk factor. Think too that exacerbation triggers are unpredictable. Think viruses, pollens, pollution, poor adherence. And think about the barrier that short-acting beta agonist has been first-line treatment for 50 years, dating from an era when asthma was thought to be a disease of bronchoconstriction. And its preeminent role in asthma management has been reinforced by the fact that it rapidly relieves symptoms and it is low cost. However, starting treatment with SABA trains the patient to regard it as their primary asthma treatment, and it's very difficult subsequently to overcome that trust and reliance. Then too, the risks of SABA-only treatment are well known. So regular use of SABA, even twice a day or 4 times a day for as little as 1 or 2 weeks, is associated with beta receptor downregulation, decreased bronchoprotection during challenge testing, rebound hyperresponsiveness, and then decreased bronchodilator response so that the patient feels like they need more. And two, there's significant evidence about increased allergic response and increased eosinophilic airway inflammation just with a couple of weeks of regular use of SABA, such as may commonly occur after an exacerbation. And then higher use of SABA, we have increasing evidence about this, the association with adverse clinical outcomes. So dispensing of 3 or more canisters a year, so that's a bit more than once a day, is associated with a higher risk of severe exacerbations, a doubling of ED presentations, and dispensing of 12 or more canisters in a year, so 1 a month, is associated with a far higher risk of death. Now, inhaled corticosteroids reduce the risk of asthma deaths, hospitalization, and exacerbations requiring oral corticosteroids. But of course, we know that adherence is poor, particularly in patients with mild or infrequent symptoms. So a safe and effective alternative was needed for mild asthma. And from 2007, GINA members pushed hard for studies of an alternative option. Now, one of the key changes in the GINA 2021 report is that the treatment figure for adults and adolescents has been shown quite differently. And this is in response to our awareness that there was an ongoing sort of subcurrent of confusion about how to implement the GINA recommendations within an individual patient across their asthma journey. And there was ongoing confusion about whether ICS formoterol could be used as the reliever in patients taking a different LABA, and it should not. So for clarity, we've divided the treatment figure into 2 tracks, we called them in the end. And this is based on evidence about outcomes with the 2 reliever choices. So track 1, I'll show you in a moment, has low-dose ICS formoterol as the reliever, and this is the preferred approach because it reduces the risk of exacerbations compared with using a SABA reliever with similar symptom control and similar lung function. And then track 2 with SABA as the reliever is an alternative but non-preferred approach. So this can be used if track 1 is not possible, if ICS formoterol is not available, or in a patient with no exacerbations on their current controller therapy, if they don't prefer the track 1 option. However, before you consider a regimen with a SABA reliever, you should consider whether the patient is likely to be adherent with daily controller, because if not, they'll be taking SABA-only treatment and exposed to the risks. And treatment may be stepped up or down within a track using the same reliever at each step, or switched between tracks according to the patient's needs and preferences. So here is the figure, and I just remind you that when you're using this figure, the top part, the arrowed circle, can be used to remind listeners about the importance of these key components of asthma management. So this is for adults and adolescents, 12 years and older, personalized asthma management. So at the top here, you have the controller and preferred reliever, track 1. So the way that this works is at any step, when the patient has symptoms, they use a low-dose ICS formoterol as their reliever to address those symptoms. So in steps 1 to 2 combined, this is their controller as well. Then in steps 3, 4, and 5, the patient is also taking a maintenance ICS formoterol treatment, and that is called maintenance and reliever therapy, or MART. And the reason that this strategy is preferred is because using ICS formoterol as reliever reduces the risk of exacerbations compared with using a SABA reliever across the spectrum. Then at the bottom here, we have the controller and alternative or non-preferred reliever. And here, the as-needed short-acting beta agonist is the reliever across all treatment steps. In steps 2 to 5, the patient is also taking a regular daily controller medication, either ICS alone or ICS LABA. In step 1, the patient takes an ICS inhaler whenever they take their SABA reliever. And I was thinking during Sarah's presentation that probably this presentation of the GINA figure makes it a bit easier to see what the options are in countries where there currently isn't access to ICS formoterol. However, as I'll show you, there is really quite strong evidence for ICS formoterol as reliever for better outcomes. So I think we need to promote access by low and middle income countries to ICS formoterol, which is on the WHO essential medicines list. Then at the bottom here, you have other controller options for either track. Now, I just want to briefly go over the evidence for ICS formoterol as the reliever in step 2. Now, here we have evidence from 4 large randomized controlled trials totaling just under 10,000 patients. So it's a very robust evidence-based. Compared with SABA alone in mild asthma, as needed ICS formoterol reduces severe exacerbations by about 2/3. So a very substantial reduction. And this was seen in a large double-blind study, the Sigma-1 study, and also in an open label study in patients previously taking SABA alone, the novel START study. Then compared with maintenance low-dose ICS with as-needed SABA, we have 4 studies. For severe exacerbations, as-needed ICS formoterol was non-inferior in 2 of the studies, the 2 large double-blind studies, Sigma-1 and 2, and it was superior for severe exacerbations in the 2 open-label randomized controlled trials, Novel START and Practical. And this was achieved with an ICS dose that was between 25 and 50% of the dose compared with maintenance low-dose inhaled corticosteroids. For symptom control, lung function, and FeNO, there were very small differences. So, for example, symptom control, ACQ, a difference of 0.1, where the minimal important difference is 0.5. And for each of these, that difference did not increase over 12 months. So there was no evidence that inflammation was continuing to accumulate in patients on the as-needed ICS formoterol. For exercise-induced bronchoconstriction, there was a double-blind randomized controlled trial published in 2014, which showed that as-needed ICS formoterol taken for symptom relief and before exercise was better after 6 weeks treatment than SABA and similar to inhaled corticosteroids in reducing exercise-induced bronchoconstriction. So patients don't need a SABA inhaler for use before exercise. Now, there were some other considerations. That slide showed you the randomized controlled trial evidence, but the other considerations, as I mentioned, that severe exacerbations can occur in mild asthma, and they're often unpredictable. That inhaled corticosteroids are highly effective in mild asthma, but patients are often poorly adherent, and understandably, if symptoms are infrequent, most patients won't want to take a daily treatment. We have increasing evidence now that even occasional short courses of oral corticosteroids are associated with increased risk of long-term and quite serious adverse effects. So, for example, osteoporosis risk is significantly increased with as few as 4 or 5 short courses of oral corticosteroids over a period of 7 years. And many other steroid side effects are also increased with just that relatively few number of courses. So we need to rethink the management of mild asthma with occasional short courses of oral corticosteroids. I just want to mention that the primary outcome variable of the Sigma-1 study was well-controlled asthma weeks. And this is often highlighted in the promotional material from one particular company that doesn't have an ICS formoterol treatment available. However, GINA did not consider this outcome of well-controlled asthma weeks to be reliable, partly because it was based on an earlier concept of asthma control, which included lung function on every day as an essential criterion, but also because the design of this measure meant that it was systematically biased against the as-needed ICS formoterol treatment group. And then a final consideration that emerged in the publications in 2019 is that phenotyping, inflammatory phenotyping, is not needed for treatment with as-needed ICS formoterol. there was no significant difference in the treatment effect compared with either as-needed SABA or daily ICS in patients with either high or low baseline eosinophils or high or low FeNO. So that's an important distinction from the approach to moderate and severe asthma, where phenotyping is important. Now, one of the questions that we're often asked is why GINA extended as-needed ICS formoterol to step 1. And this is one of the areas where you'll find differences between the GINA recommendations and the recommendations from guideline bodies that only consider the randomized controlled trial evidence. So firstly, there's no evidence for either the safety or the efficacy of SABA-only treatment. This was, it was part of treatment when the first guidelines were published in 1989, was never challenged, but it was not based on evidence. And then I keep on mentioning this because it is so important. Patients with infrequent symptoms can still have severe or fatal exacerbations. And the treatment for those exacerbations, even occasional courses, increase the risk of serious adverse outcomes. Now, there's indirect evidence about the safety and efficacy of as-needed ICS formoterol from the studies that I've shown you in patients who were eligible for step 2 treatment by either GINA 2012 criteria in the SIGMA studies or 2014 criteria in Novel Start and Practical. We actually use indirect evidence in somewhat different populations, far more than most guidelines will accept. For example, in severe asthma, all of the biological therapy studies were in patients who had variable airflow limitation with reversibility of around 25%. And we certainly don't limit our recommendations to such patients in clinical practice or in the GINA report. Now, the distinction between patients eligible for step 1 or step 2 is actually arbitrary. And again, this is something that's historical and not evidence-based. There's not any plausible mechanistic difference between symptoms less than or greater than or equal to twice a month, or the way therapy might be effective in such patients. And in past studies, there's been no difference seen in risk reduction with either inhaled steroid or inhaled steroid formoterol by symptom frequency. So this was examined, for example, in the Novel Start and Practical studies. And then too, a study that was published earlier this year, on which I'm an author, showed that even a single day of higher ICS formoterol use reduces the risk of progression to needing oral corticosteroids within the next 3 weeks. And I'll show you a slide about that in a moment. And then, as I've mentioned before, starting with SABA alone trains the patient to regard it as their primary asthma treatment. So if based on the clinical trial evidence, you recommend ICS formoterol as the reliever in steps 2 to 5, then if you start treatment with SABA alone, that throws all of your arguments to the patient, or your case to the patient for protecting against exacerbations, that makes that implausible. The goals of asthma treatment are symptom control and risk reduction across the whole of asthma severity, not just in moderate or severe asthma. I'm including some practical issues that are included in the GINA report. This isn't in the slide set, but you can find it in the information in step 2 in the report. First, about dosing. So the usual dose of as-needed budesonide formoterol is 206 micrograms, or as the delivered dose, 164.5. One inhalation taken whenever needed for symptom relief. And it works as fast as salbutamol. The maximum use in a single day with budesonide formoterol is a total of 12 inhalations, which corresponds to 72 micrograms of formoterol, or 54 micrograms as the delivered dose. However, in the clinical trials, where there was electronic monitoring on almost all of the patients, the average use in randomized controlled trials was very much less than this. It averaged around 3 or 4 doses per week. Secondly, mouth rinsing. This is often a question by patients and by clinicians. And the recommendation is that it's not needed in general after as needed doses. And this is based on evidence from around about 30,000 patients in maintenance and reliever studies and the mild asthma studies, where this was the recommendation that you should rinse and spit out after the maintenance doses, but not after as needed doses. And there was no increased risk of thrush in those studies. Then which ICS formoterol formulations are suitable for as needed use? All of the evidence so far in mild asthma is with budesonide formoterol. Now, beclomethasone formoterol is approved for maintenance and reliever therapy and is in use in several countries. So we assume that it would also be effective used as needed alone. Although the maximum dose approved for beclomethasone formoterol is lower. Other non-formoterol ICS-LABA combinations cannot be used in this way. And as I mentioned earlier briefly, ICS formoterol should not be used as the reliever with other ICS-LABA formulations. And then just to mention action plans. So there's an example in Australia that we developed in 2007 for maintenance and reliever therapy, and we've subsequently adapted that for as needed only therapy as well. So I just want to briefly show you this, this slide from the paper published, sorry, that's typo there, it's Lancet Respiratory Medicine 2021. And this shows what happens in the 3 weeks after the first day in which a patient uses more than 2 as needed inhalations of their reliever, more than 4, more than 6, more than 8. You can see that in the 3 weeks after they use more than 2 or more than 4 doses of their terbutaline reliever, there was a steep increase in the risk of a severe exacerbation, but that was knocked down to almost nothing by the as needed ICS formoterol in red or regular ICS in green there. And interestingly, a similar finding was published in 2007 from the HEAD study and of maintenance and reliever therapy, and then in 2012 from the SMILE and COMPASS studies. So this appears to be, the overall reduction in severe exacerbations appears to be related to the immediate effect over a short period of time after symptoms worsen and the patient takes more doses of their ICS formoterol. Just want to briefly show you that there are 2 figures about where to start treatment. So we suggest you show the main treatment figure first, and then there's either this figure showing where you start on those 2 tracks, or this figure. So the information is the same, but you might want to use them in different circumstances. This time sort of working downwards from the most severe symptoms at presentation. Now, I think my time is up, so I just want to emphasize one point here about maintenance and reliever therapy in step 5. Now, this is one of the things we've been asked about, and you may be asked too. So there is no direct evidence about initiating maintenance and reliever therapy in patients receiving add-on treatments such as either LAMA or biologic therapy. But the reason for carrying maintenance and reliever therapy across to step 5 in the treatment figure is that if a patient is already taking maintenance and reliever therapy, switching them back to conventional ICS-LABA with an as-needed SABA may likely increase the risk of exacerbations. So that's the rationale for carrying it across to step 5. And then I just very quickly to say that the step 5 recommendations for add-on LAMA have been expanded to include the triple therapy options. But one of the most important messages is that overall, while this improved lung function, it didn't improve symptoms. And for patients with exacerbations, it's really important to ensure that they're receiving sufficient inhaled corticosteroid before considering adding a LAMA, because extra ICS is more effective for reducing severe exacerbations. And then just a reminder that add-on azithromycin has been confirmed as a step 5 option. So in other words, after specialist referral rather than in primary care. And there's some additional evidence that it significantly reduces exacerbations in patients taking high-dose ICS/LABA, as well as in patients with eosinophilic or non-eosinophilic asthma. And then other changes in GINA 2021, the table of ICS doses has been updated, and it's important to remember that this is not a table of equivalence. So it's based on the evidence that's available, and it doesn't imply potency equivalence. Inhaled corticosteroid responsiveness varies a lot between patients. So although most of the clinical benefit of inhaled steroids for most patients is with low dose, some patients may need medium dose if their asthma is uncontrolled despite good adherence and correct technique, and a few need high dose, but you always have to balance that against the risk of side effects. And then I'll just skip through that slide for, so for additional changes, as Ted mentioned, the GINA report has a couple of pages of what's new in GINA 2021 with links through to the relevant sections of the report. And we plan this year to review the definition of mild asthma, to review the assessment of symptom control in patients whose reliever is ICS formoterol. We are going to review the evidence about allergen immunotherapy, and we'll continue to update the advice about COVID-19 as new evidence becomes available. So I'm sorry I went a little over time, but I'll look forward to having your questions and comments at the end of this session. Thank you.
Thanks very much, Helen, for this very comprehensive presentation and the great effort and great, huge work behind those new revisions. Thanks a lot. Now, I would like to move to Louise Fleming. She is the Respiratory Pediatrics Department from Royal Brompton Hospital in London, and she's a member of our GINA Science Committee, and she's going to make us a pediatrics update. Please, Louise.
Thank you, Arzu, and I hope you can see my slides.
Yes, all good, Louise. Thank you.
Great, thank you. So these are my disclosures. And again, I work with industry quite a lot, but I'm really passionate about ensuring that the needs of children with asthma are on their agenda. And so these are my disclosures. So this is all familiar, I'm sure, to you, but I think it's just worth going through some of the background, particularly in terms of the paediatric recommendations. So as we all know, the GINA strategy covers people with asthma of all ages. Recommendations for children aged 6 and older can be found in the chapters of section 1. So that's included with those for adults and adolescents. And most of the recommendations for adolescents, so that's those 12 and above, are generally the same as those for adults, unless there are specific reasons not to be. So for example, if a drug isn't licensed until 18. And where appropriate, there are separate recommendations for children aged 6 to 11 years, and that's what I'm going to focus on. Since 2019, there has been a separate treatment figure for children aged 6 to 11 years. And then younger children, in terms of their diagnosis and management, that can be found in section 2. And whilst there are different recommendations for different ages, the overarching principles of GINA in particular, the aims of preventing attacks, preventing asthma deaths, and the review, assess, adjust cycle are pertinent to all ages. So in terms of paediatric specific recommendations, all members of the Science Committee can contribute to the discussions and decisions. However, within the Science Committee, there are individual members with specific expertise, and that includes paediatric respirologists. And I've just highlighted the 4 respiratory paediatricians who are current members of the Science Committee. There are also other members of the committee who look after both adults and children, particularly in primary care. And new evidence relating to children is always reviewed by at least one paediatric reviewer. So the main change in terms of children has been in terms of the treatment figure. Some of those changes are kind of aligned with the changes that we've already seen for adults and adolescents, included such as the formatting and the colour. But some also really just to clarify some of the treatment steps and to make sure that they're consistent with the recommendations in the text. So the main changes are at step 1, and I'll show you the figure next, that taking inhaled corticosteroids whenever SABA is taken is preferred over daily inhaled corticosteroids, as poor adherence is highly likely. And at step 3, maintenance and reliever therapy with very low dose ICS formoterol is included in the figure. And at step 4, low dose ICS formoterol maintenance and reliever. So this is the treatment figure. Previously at step 1, both low dose ICS formoterol and daily and low dose ICS and low dose ICS taken whenever SABA were taken were included in the other controller boxes. However, low dose ICS taken whenever SABA is taken has been moved to the preferred controller. And the reason for that is the high probability of poor adherence if low dose ICS is recommended as a daily treatment for those with infrequent symptoms. And if adherence is poor, then children will fall back on simply short-acting beta agonists. And Helen's already highlighted the problems with that. At step 2, we still recommend daily low-dose inhaled corticosteroids as the preferred controller, as there is better evidence there that these prevent asthma attacks in children. As I said, at steps 3 and 4, maintenance and reliever therapy is included, and that's because of the evidence highlighting the reduction in severe exacerbations in children. And I saw that in the chat, Zero posted a message around kind of, knowing the evidence for the reasoning behind these, the recommendations within the GINA guidelines, within the GINA strategy. So I've just summarised here the evidence for ICS formoterol that includes adolescents. So remember, adolescents are included within the adult recommendations, and both Sigma 1 and 2 included young people from the age of 12 years. And in fact, there were almost 900 adolescents included, and the evidence for them has been reported separately and reflects what we see in the main results for Sigma 1 and 2. The other studies of ICS formoterol, novel start and practical, were adults only. So in terms of the recommendation of using inhaled corticosteroids whenever SABA is taken, that's based on 2 studies in children and adolescents, the TREXA study and the ASSIST study. And I'm just going to go through those. So TREXA actually was from some time ago now. And this was looking at beclomethasone as a rescue treatment for children with well-controlled mild persistent asthma, and used at the same time as albuterol. It was quite a complex study with 4 different arms, and all children had 3 inhalers, so 1 maintenance inhaler that was either beclomethasone or placebo, and 2 rescue inhalers that was a combination of two of the three inhalers included, so either beclomethasone, albuterol, and placebo. And in fact, because all children had 2 rescue inhalers, they were taped together to remind them to use both when they were for relief of symptoms. And the primary outcome was time to first exacerbation. So those in the salbutamol only arm did the worst in terms of time to first exacerbation. In the adjusted analysis, only those on daily inhaled corticosteroids had a reduction compared to SABA-only treatment. However, a secondary outcome was treatment failure, defined as either a second prednisolone burst or hospitalization. And in that analysis, all the arms were better than the salbutamol-only arm. So salbutamol only in children with mild asthma substantially increased the risk of an attack. Daily inhaled steroids was the most effective, but treatment failures were less in children treated with rescue ICS compared to SABA only. The second study was the ASSIST study. Now, this was a study just carried out in African American children aged 6 to 17 years managed in primary care. And this was an open label pragmatic study. Children were either randomized to symptom-based adjustment, where they took beclomethasone plus albuterol when they had symptoms, or those in provider-based guideline-adjusted treatment who took beclomethasone regularly plus as needed albuterol. And the primary outcome was the change in asthma control test or childhood asthma control test score. So in terms of change in score, there were no differences between the two arms. Also, secondary outcome exacerbations, again, no difference as to whether the inhaled steroid was taken regularly or only as needed at the same time as short-acting beta agonist. And similar to the results from the as-needed ICS formoterol study, the dose of ICS that the children took overall during the study was far lower, so around a quarter of those who took it regularly. There's only one study of maintenance and reliever therapy in children aged 6 to 11 years, and this was the Hans Bisgaard study, or a 12-month double-blind randomized control trial, and children were randomized to 3 arms. So either the MART arm, where they took budesonide formoterol at a very low dose, so 80 over 4.5, which is the 100 over 6 dose, once daily for maintenance, plus additional doses for symptom relief. Those in the fixed combination group who took that dose once daily, plus short-acting beta agonists for symptom relief, and then those on a higher fixed dose of budesonide. And here we see both in terms of the percentage of patients with an exacerbation, and in both these figures here, those in the MART arm did significantly better than those either in the fixed combination or the fixed dose of budesonide arm. And there was a reduction in exacerbations by 70 to 79% compared to those other 2 arms. So based on this study, MART has been recommended for younger children and is now included in the treatment figure. As I say, MART has actually been recommended within the text for some time, and it's been added to the figure for clarification. So the plans going forward, we're aiming to complete the review of section 2, so that's in children 5 years and younger, and just reviewing that section, focusing on the diagnosis and management of younger children. And we're also hoping to produce a pocket guide for difficult to treat and severe asthma in children aged 6 to 11 to go alongside the pocket guide for adults and adolescents. So I'd like to thank all members of the GINA committee, and thank you for inviting me to speak today.
Well, thank you very much. Very nice presentation about children. I think we will open the discussion period. If you have questions to the speaker, you may preferably go to the chat room to ask questions, or you can open your camera and unmute you if necessary. I think we have about 30 minutes left. If I may, there was a discussion in the chat room, as you could see, about the fact that there is a perception, maybe this is for Helen, there is a perception about the fact that GINA, for some people, seems to be an opinion-based document, less evidence-based, that there is a problem with the ICS formoterol on demand compared to the long-standing ICS alone or with SABA. Could you maybe summarize your opinion about that, Helen?
Sure, thanks, Louis-Philippe. So look, firstly, I think we should acknowledge the difficulty of changing something that has been part of bread and butter asthma management for a very long time. It's challenging for physicians and for patients to change their perspective about what is needed to improve asthma outcomes. So, I don't expect that it will be a fast process. In terms of the perspective of GINA, we also need to acknowledge that there are some commercial issues at play. You know, that is contributing to some of the conversation. So it's really important that we keep on talking about the strength of the evidence, because that's the reason for these recommendations. And I think the fact that other guideline bodies, when they review the evidence, stop short of recommending ICS formoterol in step 1 is something that we need to explain. And so that's why I've put in a slide about it in the slide set, to explain that this is not necessarily, that the decisions in step 1 are not necessarily dependent on there being specific studies in patients with symptoms less than twice a month. I can imagine how difficult it would be to recruit for such a study. But looking at asthma management as a whole. So look, I think it's going to be a slow process. We need to emphasize that this is not an opinion. It's based on solid evidence, and that the focus should be on improving outcomes for both symptom control and for risk reduction.
Thank you very much. Arzu, if you have any question also, but maybe before asking you to maybe take over for the question, Mark Levy is with us. You're with us, Mark. I think there is an increasing demand of involvement in social media to disseminate and in fact the uptake of the guidelines these days. Do you think we can improve that? What is your concept about the role of social media for GINA?
Thanks, Louis-Philippe. I think it's very important, and it's an opportunity to get to a wide audience. For example, in the last week, 3 tweets on the new 2021 update reached 45,000 people. So please use your social media to share ideas, and always put a link to the GINA website in your tweets, because I think that'll help get more activity, because essentially we want people to read the GINA document and also look at the other resources on the website.
Yes, thank you. And before my last question, before I pass to Arzu, maybe it's for anybody from the speakers. I know that a few years ago, there have been discussions about providing some publicity about the recommendation to the general public, thinking that maybe if people know what they deserve to get in regard to confirming the diagnosis or in regard to treatment, that could improve the situation. And in fact, we had example of patients requiring to their physician a test or a treatment and so on from guidelines. We know that we have a patient guide. We have some translation. Probably we should translate it in more languages. I don't know if somebody wants to discuss about the role of informing the public and the patients about the recommendation from GINA, maybe to influence the health practitioner or make them aware of the recommendations.
I can comment on that from a translation perspective, and I would love to have the patient guide translated to as many languages as possible. So I see that Michaela has joined us. Thank you very much for your wonderful presentation, and I will take you up on your suggestion. So separately, if anyone would like to work with me to translate into your native language our patient education materials, please contact me and we'll get that done with urgency. We have a wonderful tool for patients with great little animations in the guide, and we need to have it translated more efficiently. I do have a question for Michaela while you're here in your presentation regarding your survey. 2 questions. Number 1, was it all adults that were surveyed? And number 2, were they only in the public health system, or did you include people with private health insurance in those countries?
Oh, I think Susanna Palkonen is here also, because she knows exactly who took part in the. But I think it was only adults. They were interviewed. But when it comes to Susanna, are you there? Or she can write.
I am.
Yeah.
Yeah, so thank you for the questions regarding the private or public health insurance. In fact, because we are talking about Europe, So in principle, everybody is within the public health insurance, but this differs from countries. Like in the Nordic countries and in the UK, it's like centralized, whereas in many other countries like Belgium, the Netherlands, and so on, you have the so-called mutualité that you have to subscribe to as a person in order to have the health insurance that you deserve, but it is not private.
So Susanna and Michaela, we'll take that together as a separate conversation, but thank you very much. We had a question come through, maybe explaining the difference of the risks between oral corticosteroids and inhaled corticosteroids. I'm not sure if that was a question or just a suggestion that we should do that in the guide. So Helen, if you want to respond to that, maybe.
Yes, I think that's one way of tackling it, because in the past, the idea of using just short-acting beta agonists for symptom relief and then an occasional course of oral corticosteroids, you know, for example, if it was say once every second year, that was seen as a very effective, low cost and low risk strategy. But I think the evidence from that study by David Price, published in 2018, is really quite shocking in terms of the evidence for increased risk of osteoporosis with as few as 4 or 5 courses, essentially 4 or 5 lifetime courses. So we need to look at this differently in terms of our perceptions of risks, and not just think of managing asthma as sort of as if it's an infective condition, as if it's just short-term treatment. We need to think about the long-term implications.
While we have so many advocates in the room, I would like to learn their recommendations and suggestions for the implementation and dissemination in their countries, and their considerations or their suggestions for us as GINA Board of Directors and the GINA Science Committee to make GINA more visible, more implantable. I would very much like to hear the voices of the advocates, please.
So Tanya Winders here with the Global Allergy Airways Patient Platform, also the CEO of Allergy and Asthma Network in the US. So absolutely, I think that some of the comments that have already been made around the use of social media, digital media, I love the short videos that have been produced. I've already sent Rebecca a message in regard to our willingness to help on the translation and dissemination of the patient guide more broadly. But I do think it is using multimedia approaches, multi-channel approaches in order to keep these messages simplistic and drive that patient empowerment of knowing what the best level of care looks like in accordance with the guidelines.
Thanks. Any other opinion?
Michaela here from IFA. Yes, like I said in my thank you. Like I said in my speech, to use the patient organization, like Tanya said, because when I started being active, I never heard when I went to the doctors about GINA guidelines. It was just, okay, this is the recommendation you are taking, but there was no word of GINA. So if you make the association aware, then we can speak to the members, and then the knowledge will increase.
Okay, thank you. Pierluigi, we had a great activities report from you. Would you like to say anything? You're muted.
Sorry. So yes, we consider this initiative very important, as you know, and I think that we need to create a lot of discussion about this point, because I mentioned it in my question, there is some resistance to move from the strategy that have been used for a long period of time. So in this way, we need to create more consensus about this new approach. And I think that we are working on that. We will have in 10-15 minutes a meeting with a group of delegates, Italian delegates, in order to discuss this new further change in addition to the changes that GINA did 2 years ago. And this is a difficult task because you know that many doctors have some resistance to consider rescue medication as a correct way to treat asthma. But I think that the data reported are very strong, and I need to create some opinions on that. As I asked to Helen a few minutes ago, when there is so strong resistance to move in this way, can be more useful to suggest not using SABA, a rescue medication, when another ICS LABA is regularly used, but move to ICS SABA. I know that no real data have been reported about that, but could be better than nothing. What do you think?
Would you like to answer, Helen?
So Pierluigi, thank you for that suggestion. So I think in Italy you have access to a combination ICS SABA, but it's certainly not widely available. There are some concerns about the acceptability to patients of carrying around 2 reliever inhalers. So in the ASSIST study and the TREXA study, separate inhalers were used, but they were in children and adolescents. I think in adults, it's probably, it's going to be more difficult to get them to carry 2 inhalers. And it's likely that what would happen would be they would revert to just carrying 1 inhaler. So there are more new combination ICS SABA inhalers being developed, and I understand that some of the studies at least will use those as the reliever for patients on an ICS LABA maintenance treatment. So it'll be good to see those results. We need to particularly though look out for whether it's safe in patients who use their reliever more frequently than just occasionally, because in the in Alberto Papi's study published in 2007, the patients who received ICS SABA twice a day actually had more exacerbations than those who were randomized to ICS alone. And there's some discussion in that paper about the potential risks of regular SABA treatment that may not be overcome by combining it with ICS. So, you know, that's why there's a qualified recommendation about using ICS plus SABA together as the reliever. I think we need more evidence, but, you know, I mean, essentially any ICS is better than none. So, yeah.
Yes. Okay.
Yeah, I don't know. Could I have a word?
Of course, Desiree. Of course. Go on.
Hi, thank you. Because it's exactly, I don't know, you saw in the chat, it's exactly the issue we've been discussing about now in our Mexican asthma group. We just launched yesterday our new asthma guidelines here in Mexico, surely still based on GINA 2020. But yeah, the big problem here at primary healthcare is that there's only SABA that what the physicians are able to prescribe, and we are now struggling to get also the ICS in there. But then to have ICS formoterol primary healthcare, that is still another step away. So in our national guideline, we opted exactly for what our Italian colleague is just discussing, to tell them to, when they rescue, always do 2 puffs of the SABA and 2 puffs of the ICS. So never have only a SABA. I thank you very much, Helen, for the comment on the PAPI study. Yes, it was striking there to see that the ICS SABA maintenance and rescue did worse. Now, so yeah, you really have to be careful to not go to maintenance with the ICS SABA, but to, when you already have your ICS as maintenance, rescue with the same SABA plus 2 extra ICS, I think might be quite a good option if you only have those two inhalers. And sure, yeah, if the people have a little bit more money, then they should go out and buy the ICS formoterol, but it is still quite expensive in my country.
Yeah, I think that emphasizes the importance of lobbying for governments to provide access to ICS formoterol, good quality, low cost. And I think health economic calculations should be done to take into account those long-term costs of osteoporosis, cataract, etc. You know, they have measurable costs that can be quantified over a period of, say, 10 years, rather than just considering the costs of oral corticosteroid, as in, you know, the cost of half a dozen tablets. Yeah. So for low and middle income countries, the lobbying of government is going to be crucially important.
Yeah. And here, WHO essential drug list is very important, I guess, Sarah, for the low and middle income countries. It is really a big problem. Any other comments?
Could I speak?
Okay, then Gay and Hugo, please. Okay, go ahead.
Thank you, Arzu. So I'm a great fan of GINA, so you all know, and the science is perfect and very good. And I was very much struck by the report from Michaela on how the patients are experiencing their asthma. And it's really, for me, also a little bit sobering that we are in 21 and in a lot of countries, a lot of good medication is available, but patients report that they are suffering from their asthma. We have done recently also in Belgium an inquiry in about 1,200 patients with asthma, and about 1/3 spontaneously report that they are really in need to have more information, and they report that their asthma is not under control. Why do I bring that up? Of course, you all know that, but when you try to do something in your national country, there are a lot of barriers that you have to go through before you reach the important stakeholders. Yeah. And if I see all these GINA advocates here together, I'm really thinking about you, Arzu, and colleagues from the implementation committee. Shouldn't we set up meetings to exchange ideas how to go around with nice examples? There are nice examples of asthma plans, but what can we do to facilitate this in our countries? So that would be of much help, I think, if we can inform each other how are the best ways to tackle rather big issue about implementation. So it would be great to be able to do that with you.
Yes, thank you. Thank you for this suggestion. Hugo?
My comment is regarding the limit or the border between step 1 and 2 and step 3. I discussed this topic with Helen by May, but in our country, it's a person, it's an asthmatic patient, has symptoms less than 5 days a week. It means 16 days a month. The pneumologist, allergologist, and primary care physician, a patient with symptoms 16 days a month put under fixed combination with 2 strategies, or MARS strategy or another LAVA plus ICS, plus LAVA plus ICS. In my opinion, is better to put the limit, symptom limit between step 1, 2 and step 3 less than 4 days a week. I know Helen answered to me that the published paper not is precise in this topic, but when we transmit GINA strategy to the primary care physician in our country, in my opinion, it's necessary to precise the limit, because the strategy or the physician in our country prescribe a patient with 16 days a month with symptoms, prescribe fixed dose. If the patient is less 12 days a month, have symptoms, probably prescribe as rescue budesonide plus formoterol. But if the patient has more symptoms
prescribe a fixed combination by MAR strategy or by another LABA plus ICS.
So can I just add, Arzu, that my response to Hugo was, in fact, that because the studies did not show that there was a difference in benefit according to low or high reliever use, that this is a situation where I would ask the patient. So if the patient is happy to use as needed ICS formoterol on 4 or 5 days a week, then provided they're not having exacerbations, I would be comfortable with that. But if the patient wants to take it regularly at that point, or even at a lower frequency, that's where patient perspective should really be taken into account, where there isn't a strong indication from the evidence.
Thanks, Helen. We have 7 or 8 minutes. I see the hands raising. Sarah first, Iwa, and Michaela. Sarah, please.
Thanks, Arzu. I just wanted to comment on your comment about lobbying governments in low middle income countries. And I think it's absolutely true, but it's also important to realize that there are many competing demands made of the healthcare budget in countries with limited resources. And so I think cost effectiveness data is absolutely key, because if we want to make an argument for something that, you know, that is going to be beneficial to a country, they need to know what the costs are. Ideally, that data would come from low and middle income countries. That's always a challenge, but even, you know, more data from high income countries, as people were mentioning about the long-term costs of oral steroids, I think would be helpful. It's just something I think is absolutely key. I think without data and evidence, it's very difficult to make a convincing case that's going to have enough weight. That's what I wanted to say. Thank you.
Thanks. Eva?
Yes, I think that it's very important to introduce the new solutions, track 1 and track 2, for our textbooks. As I have already said, we have a big textbook of internal medicine, which is updated each year, and the smaller version, this is for students. This one for specialists in internal medicine and for specialists in allergy, respiratory medicine. And I have decided with the other authors of the chapter of asthma that we'll introduce in the edition internal medicine to 2021. And I think it's very important for students and for people who are starting their specialization to have it already in the book, in the textbook. Because, you know, it's much easier, I think, to teach younger people since the beginning of their career how to organize treatment and not to use SABA when the attacks of asthma are quite rare. So I think it's very important, and even in this edition 2020 we have already mentioned about this, that SABA should not be used, and that we should use budesonide formoterol, which is available in Poland, and also we have beclometasone formoterol, also could be used in Poland. And I think we realize that it is now frequently used by specialists, and now we should also go to the internal medicine specialists and general practitioners.
Thank you, perfect. Michaela, can I have a short notice from you, because we have 3 or 4 minutes?
Of course, and this is a positive one. I just want to say I've been a patient advocate for some years now, and there's been a change now. We are more included, so we are on the right track now. So I just want to say that this is the start, and what you said before, to exchange experience, I think that is good. but we are on the right track, and just keep going, and then more will know about GINA, and again use the patient organization, because this is a teamwork. We must work together. Thanks.
We're lucky to have all of you.
Yeah.
Louis-Philippe, would you like to say a closing remark before we close?
Arzu, could we just address one? It's a very important one in the chat. There is, can we discuss for a few seconds what is expected from the advocates? We are providing national entry doors. What's the best way to do this? National events, national GINA webinars. So that was a question that came in. I think it's important to talk about expectations quickly before we end, but I'll just briefly say thank you for everyone for joining us and for sharing all of your important activities that are going on. Please reach out to me separately for questions, or let me know how I can best support your efforts.
Okay, I really admire those questions, but we don't have time to discuss it. So maybe I remember something that we can do. We can have a report of this meeting, and we can collect all of the our expectations from our advocates and send them by email and have their feedbacks again, because we have a very excited revision of 2021 in this meeting, so we couldn't have time to discuss, but we will keep going on these advocate meetings in every 3 or 6 months, so maybe at a shorter period of time, so we can have the possibility, we can have the chance to discuss what we can do as advocates. Louis-Philippe, would you like to say something for closing remarks?
Thank you, Arzu, for helping me with sharing this session. And also thank you for all participants, Rebecca and your team. I think it's been wonderful. I think we should keep discussing how to improve advocacy for GINA, answer some questions, some key questions. I think there are always very good questions. I'm very keen, in fact, to develop a structured document of frequently asked questions for healthcare providers. I think we have one for patients. We can improve the patient fact document. But I think it would be nice, maybe, because very frequently it's all the same questions. So it would be very nice to have a fact document for clinicians, I think, as it's been mentioned. So thank you to everybody. I hope you have a good day or a good night. And we should keep the contact and further discuss this. Thank you to everybody.
Okay. Thanks very much, everyone. Lucky to have you.
Bye-bye, everyone. Stay well. See you soon.